Good evening and welcome to another episode of The Round Table. I'm Asha Mwilu. Tonight we have a very special dinner with doctors. To my left, Dr. Wanjati Nambagen from the Kenya Methodist University, academic in financial health, financing health, governance, and devolution. And then we have, of course, Dr. Andrew Mulwa, who's not new to us. He's the chairman of the health CACs, the county CACs. Dr. Jacqueline Kitulu, national chairman of the Kenya Medical Association, also not new to our screens. And of course, MP, Seme constituency, currently Dr. James Nyikal, not new, member of Parliamentary National Assembly Health Committee. Welcome to the round table. I mean, listen, the big question that everyone is asking, should we be worried when we're hearing that donors are now cutting funding going into the health ministry?
I think there is a big reason to worry as a country when donors start pulling out of financing health in this country. But again, I look at it as a positive and say it's time that Kenya and as a country we start reevaluating ourselves and look at the resources that are within ourselves that we can apply to deliver health to our people. Because we depend on donors in a lot of things. The HIV/AIDS program, the TB program, the malaria program are like donor funded entirely. So I think it's also time for us to ask ourselves, how much do we continue relying on donors to deliver health to our people?
I think I'd look at it in the short term. It is a worrying trend because the donors fund certain programs, very large programs, and so with the current suspension of funds from USAID, there's very many areas that are going to be cut off in the Ministry of Health, even including remuneration for certain cadres of staff, in terms of very many programs and things that are cut short.
But I mean, the clarification, I just want to jump in. The clarification from the ambassador was that they are not going to cut funding to those crucial areas like HIV/AIDS. That this is only what the ministry uses, administrative, exactly.
Administrative support.
Administrative support. But when you look at what donor funding does, in terms of the percentage that it contributes, and we are looking at over maybe 30% of our funding of health.
Yes.
That's a big percentage. If all those pulled out immediately, that's a big problem we are going to face. However, part of what Dr. Mulo mentioned, that it's probably a good wake-up call, because there are challenges with depending largely on donors. The financing is unpredictable. Here's a good situation. The funding has been cut. There is good reason, and maybe that's a further subject we'll discuss. But short term, it may be unpredictable. There's high admin cost, and then sometimes the programs, where it goes, it's very vertical programs, a particular program that's funded. So that in a sense, I look at this as a welcome point for us in terms of looking at healthcare financing, opening our eyes to focusing ourselves on self-funding. That's probably the direction we should be looking at.
Actually, Dr. Wanja is a big proponent of that.
Yes.
What you were explaining to us about donor funding versus self-funding in Kenya.
In my view, I believe that the country is moving towards the right direction. It's a pity that now we are talking about the situation we are in, because of the ministry and the things that have happened, and accountability and all. But I believe if you look at the trend over the last years, we have seen that Kenya is putting in more and more self-funding in terms of raising its own taxes. And I believe this will be a wake-up call for all of us, not only in the Ministry of Health, but also in other sectors where we are talking about how can we improve in issues of leadership and governance, accountability issues. What are we doing? How are we engaging the stakeholders? So the donor funding should come in as a stop measure. But it's not something that we should rely on. We should raise more funds from the government to put it into the health sector.
As someone who actually worked in the Ministry of Health, when you hear that 2.1 billion shillings, the ministry is going to miss out on this sum of amount, what does it make you think?
We should be worried, because in the short term, programs are going to be affected. People are going to be affected. The truth is, some people will die.
Can you explain to us how?
Now, if you have a program and you say you are just not, you are supporting the program but not the administrative cost. Remember, it is the administrative cost that drives the program. If you have the drugs and if you have the equipment, but you don't have the administrative cost that one will train people on how to use the drugs, will train people on how to use the equipment, will actually supervise how they're done, then actually that doesn't work. I mean, we've had similar problem in government before, where they are saying we are going to cut out things like workshops, we are going to cut out travel, and people don't realize it is when officers travel and go out to the field that works gets done. So that then you can have money that is sitting there and not being efficiently utilized because you don't have the administrative cost.
Yes.
But the main thing is with health is those who suffer don't have the opportunity to recover, particularly if they die. So you don't want a break in the health system, you want continuity. Now, it is really maybe a wake-up call, but I'm unhappy because this is something we've known from as far back at 2003, 2005. Look at the HIV program that is heavily funded by donor funds.
Yes.
Look at the immunization program. Look at the malaria, TB, and reproductive health. These are areas that are heavily funded. Up to actually 40% of that is donor funding. Now, as way back as 2005, when we were getting the money, we had a program that had said, how do we start building our own resources so that when such a time comes, and we were thinking around this time actually, then we will be there with adequate money. Look at the Gavi, the immunization program. It started with saying you have to put in some of your own and start building it so that later. So
And it's interesting that you've mentioned those years, because when we think about healthcare financing, we don't think about the history of it. And I just want our viewers to maybe take a, let's just peel back the pages of our history and try and understand where did we come from 1963. Take a look. It's been a muddy affair ever since we got independence from the British. Well, to be fair, the Kenyan government started out well, with a people-centered approach. Just 2 years after independence, government knocked off user fees that were set in place by the colonial government. Kenyans would no longer pay hospitals directly to access healthcare. Instead, government funded health using general tax. But the dream didn't last long. By 1988, government was sent back to the drawing board. The economy was on a decline. Kenya didn't have enough money, and the health sector was getting lower allocations, which meant that, health-wise, we were doing poorly. In 1989, user fees were reintroduced and then again suspended in 1990. The hurried implementation made more Kenyans avoid going to hospitals even when they really needed to. Plus, there was no system to monitor the revenue collected. So government's best bet was to reintroduce user fees gradually. Instead of charging for consultation, Kenyans paid for individual services like injection, medicine, and lab services. Oh, and the revenue collected was returned to the district level to cater for public needs. There was now a system. So does it mean that Kenyans became the primary funders of health? Well, the devil is in the details. By year 2001-2002, out-of-pocket payments comprised of 51.1% of the total amount spent on health. Government's contribution was only about 29.6%, which meant that direct fees paid by Kenyans was the largest source of health funds. By year 2005-2006, out-of-pocket payments were 35.6% of total health expenditure against government's 29.3%. But by year 2008-2009, the trend had changed and government had stepped up. Government contribution accounted for 35% of the sector's expenditure and households contributed only 24%. But there was also another notable trend. Donor aid into Kenya's health sector was increasing. Donor contribution to our total health expenditure in 1994 was only at 8%. But in 2001, 2002, it shot up to 31%. In 2008, 2009, donors contributed an estimated 40% of our health expenditure.
And by the way,
So doctors, if we think about our history, where we've come from, and looking at how donor funding into healthcare has really increased over the years, especially after the mid-2000s, are we worried now that a program like PEPFAR, which is very crucial to us, might actually disappear anytime now because there's a new administration?
We are worried, but we shouldn't be, because this was foreseen, as I said. When PEPFAR came in all these programs, at the beginning, there's always an agreement that as we put in this money, the country should start putting in money and have increases annually.
Have we done that?
We haven't, and that's the problem.
And actually, those are some of the disadvantages of donor funding. Then, because as countries really can't, in terms of progressing towards a point of, say, universal coverage, really it should be public health financing.
Yes.
So the government should be putting quite a big chunk of the money towards that. But where you have donor funds coming in to run several programs, there's a tendency for governments not to actually put in the amount they should, because you see that gap is being met.
Yes.
Because and not necessarily intentionally, as I think we've just had a chat here with Dr. Mulwa, there are other competing needs. So if there is someone else meeting that need at a certain point, the funds go to something else.
Right.
So those are some of the challenges. Yes, you'll have benefits, but you also then have challenges because then you don't adequately, budget for.
You would
for
think that we should be able to mitigate that, especially because we are signatories to the Abuja Declaration. How are we doing, Dr. Wanja?
With the, we are still quite low when it comes to the Abuja Declaration. We know we should be giving. The Abuja Declaration says it should be 15%.
Of our national budget to healthcare.
Yes, to healthcare. However, we are just barely at 6%. So definitely the government is quite low in terms of funding. However, we have seen, as we just had a conversation here, that counties on average are giving up to 22%, which is a plus. So moving from when we started devolution from an average of 13%.
22% of 15%.
22% of it's a percentage of the other percentage.
Of what? Of
15%, because the counties get 15% of the total national whatever, or thereabouts. So it is still low, even that.
It is still low, but at least we are seeing a positive trend towards even this, although it is little, but it is worrying because what are we doing? How efficient are we in using this little that we have in terms of ensuring it that it is reaching to the people and the quality of services and so on. So there's still
I think part
questions
of the challenge with that also is in terms of that amount that should be, yes, it was said 15% to be allocated of the annual budgets of countries, of the AU states.
Yes.
And I think there's only 6 countries, AU countries, that are meeting that.
Yeah.
Liberia, Madagascar, Malawi, Rwanda, a few, meeting that budget. But when you look at it, it's the challenge here is also in terms of the health ministries of health. This is the budget they want, but they are not. That budget is not discussed entirely by themselves. There is the treasury to discuss that with. There's the bigger picture, so there is engagement probably at very many different levels that prevent us getting that actual 15%.
And what about even the information? Is it flowing? Because one of the tenets of the declaration was that the governments would actually be very open about where it's sourcing for the funding, how it's being utilized, the governance around it. Do we see that at all in our country?
I think that has not really quite happened. And I wanted to interject what Dr. Chiri was saying. I think first, I would not be worried about the 15%. I'm worried about that 6% that we have as a country. How do we apply it? First things first. They always say prevention is better than cure.
Yes.
How much of this money is going towards direct investment toward primary healthcare? Because if you relook at the Kenyan budget, there is so much that is going to agriculture, that is health. There is so much that is going to water, that is health. How have we been able to reorganize that 6% and those other relevant sectors that are determinants of health?
Yes.
Because if we are able to address that, and really, if primary healthcare was to be given the right attention, even this donor financing, because when you look at HIV/AIDS, when you look at malaria, when you look at TB, there's so much that prevention can do that we actually may not require all these donor financing.
Actually, how much of that do we think about when we're even formulating our policies? Do we think about prevention, or our majority of our money, a big chunk of it, where does it go to?
It goes to curative, to infrastructure.
Yeah.
But it goes to really infrastructure and curative services. A large chunk going like to the level 4, level 5 hospitals, which with more specialist care there, and so they take in quite a bit.
But
of
I
the
think
chunk of
someone
money.
will ask, do we have the data to back our decisions? If we're going to talk about preventive care, do we have data coming from universities to tell us that, in central Kenya, it's more lifestyle diseases that we're noticing. It's more like the diabetes, the high blood pressure, and then now we know how to invest county by county, or do we just wing it?
Let me interject. There is evidence that if you actually put money in primary health care, you will actually get bigger dividends. We have evidence in this country. Between 2003 and 2008, although with donor funding, a lot of money was put in primary health care, particularly in areas of malaria, in areas of HIV prevention,
Yes.
in areas of TB. And we actually saw a significant change in the health indices between 2003 and 2008. It is actually remarkable. So the evidence is there. The ministry itself, as one of the the components of health systems, is health information system.
Right.
That in itself will give you that information. What really we've suffered from in this country is lack of continuity when we put up programs. Now, when we started in 2003, there was a significant improvement things. Then when the ministry was split, it had a bump, because when you split the ministries, it's a structural thing. It changes how things are done. Again, when we came to devolution, again, there's another big bump because the systems have not been put in place. So these things like health information, we are just talking about how much of our money goes, what percentage of the budget. You see, we are not actually sure. 6% is what goes to the national government.
Yes.
Now, what goes to the county government, I don't think we have had data to actually look at it. Some people are putting 6%, as high as 30%, but that is of the 15 or so percent that has gone to the county.
Right.
Do we have the data which now put it together? If you put county and if you put what is in the national government, what percentage is it? Are we 7? Are we 8?
I mean, it appears that we're not even monitoring what we're doing with our health sector. Are we? Is there someone taking the data, looking at the trends, seeing the mistakes that we're making in the past?
I think the evidence is there, but in this country we have a way of not using evidence when we are making policies. Because from the university where I am, we are continuously doing research. We are channeling research, but where is this
Where
evidence?
does it go? Do you
Where
publish
does
it?
go?
Do you publish the research?
We are publishing and we are encouraging our students to publish, but as a ministry, there's a disconnect between the academicians and the Ministry of Health, if I may put it, or the counties and whatever else it will be. But the evidence is there, but we do not use that evidence
Yes.
to make decisions. And these are some of the things, when we are talking about issues of governance, that we need to put the stakeholders together,
Yes.
so that when one arm is producing this evidence, can we use it to make decisions that will make a difference? I would like to agree with what you have said. Primary care is really has been neglected as a system. If we can, we all know, correct me, I'm not a medical doctor, but if we can put in, we know that 80% of all diseases can be cured at the primary level. But where are we putting our funding? Where are we putting our funding?
We have a very good example in our neighbor, Ethiopia. whose GDP is, I think, a third or below of our GDP. And they have decided to invest in primary healthcare. And issues like diarrhea, issues of home deliveries, maternal mortality, they are almost forgetting about such issues because their focus is prevention.
But whose role is it to take care of primary health
really
care?
has to prioritize as a
Especially
country.
now with devolution. It sounds like it's the county's responsibility.
Yes, it is actually our responsibility.
So what are you doing about it? Because you're telling us, we need to focus on primary health care.
Counties are fairly young, and we are toddlers.
Sounds like
And
the age
first,
old.
we had to adopt, to inherit what we found, a system that is skewed towards prevention, curative
care,
where a CT scan is better than clean water for the people, where ultrasound is bigger, theaters are bigger. So we first had to inherit that, make it work first, then we slowly now refocusing our attention on primary health care.
But
I think it goes back to policy issues.
Yes.
Because it starts with the policy formulation. What is going to be your priority? If you're going to prioritize on super specialized care and have MRIs in every county,
Yes.
and yet you have diarrheal disease killing children, then you see there's a mismatch in your priorities. So it's the policies again, and then effecting those policies. We've said the national government is responsible for policy setting,
Yes.
and then that's translated into implemented at the county level. So that in a sense, even when we say health is devolved, really it's more of it's not totally disconnected. There are different arms doing different things, but it's the implementation of those policies.
And I would want to ask this actually to Dr. Mulwa, because some CECs, health CECs, won't be here in the next cycle of devolution, maybe because the governors won't get the seats. What will be the legacy of your current crop of health CECs? When people look back and say the first cycle of devolution, the health CECs did one thing, what is it?
What would I say? I think on the issue of first commodity supplies, because what we inherited as health sector in this country was public health facilities would have commodities for 2 weeks, then stay without commodities for 10 weeks, then commodities come at the next quarter.
Right.
Currently, I think the stockout levels are below 70% of the time, on average. There are some counties like Makueni where I'm proud and can say 100% I have no stockouts. And this is something that I would say, yes, as counties, we've been able to manage that fairly well. Of course, we've done a lot of mortar and brick investment in infrastructure,
Yes.
which probably, if its effects will be felt in future. The other thing that we've done a lot is the expansion of primary healthcare facilities. I think we've done like 2,000 new primary healthcare facilities,
Yes.
which is a huge number. Maybe not commensurate with the economy of our economy,
Yes.
because sometimes that growth may be political. But of course, they are when we finally now refocus on primary healthcare, they will come in handy, and that will be something
All
that
right.
I would say
Well
we have
said. I
done.
actually want us to take a breather. When we come back, we'll actually look at how much counties allocated over the last 3-4 financial years to healthcare vis-a-vis their county
When we
budgets.
come
Hold
back-
that thought, Dr. Nick. Let's just sip some water, and then when we come back, you'll be the first one to go. Keep it round table. After the break, it's all about devolution and health. What have the counties done? How much have they allocated, and what difference have we felt?